Welcome back, everyone. We're on to our next session, bringing new voices to research and building capacity. I'm going to hand the virtual baton over to Raissa Amany, our moderator for this session.
Thanks, Rebecca, and hello, everyone. Before we get started with the session, I would like to encourage everyone that throughout the session, feel free to use the Q&A function to submit your questions to our panelists. And to introduce myself, my name is Raissa. I use she, her pronouns, and I'm from the unceded and unsurrendered territory of the Algonquin Anishinaabe peoples, or presently known as Ottawa, Canada. I'm also the executive director of the Young Canadians Roundtable on Health, and I also live with chronic migraine, and I serve at the pleasure of today's moderator. So now I'm going to invite my fellow panelists to give a quick introductions about themselves. I'll start with Stephanie Paravan, and then Patricia de Luca, and last but not least, Oluwafemi Ajayi. So Stephanie, please go ahead.
My name is Stephanie Paravan. I am also in Ottawa, Canada. I am the caregiver of my youngest son, who is 17 right now, and he has many medical complexities as well as disabilities. And he is the main reason for me being here. Although you cannot see him on the camera, a lot of my responses come from discussions that I've had with him.
Thank you, Stephanie. Patricia.
Hi, I'm a physical education professional, mom, wife, and a person living with high cholesterol since birth. And as an advocate for the cause, it's very important to find people living with FH at the first opportunity. Test for your own blood cholesterol. If it is upper of 300 milligrams per deciliter, think FH. And for children and adolescents, 230 milligrams per deciliter, think FH. FH runs families and has treatment to avoid cardiovascular disease. So thank you for inviting me. It's going to be, I'm very pleased to talk with you.
Thank you, Patricia. Oluwafemi, please go ahead.
Hi, everyone. My name is Oluwafemi Ajayi. I have sickle cell disease. I'm also the CEO of Girl Sickle Initiative, a nonprofit organization for people living with sickle cell disease like me. And I'm currently running my doctoral studies at the University of South Africa, which focuses on the lived experience of people living with sickle cell disease. Thank you for having me.
Thank you all three for being here and having this discussion. I'm very excited to have this discussion as well, as someone who just entered the patient partner research about 2.5 years ago now. But I would like to start with this question, and I encourage everyone here to contribute and provide your opinion and expertise in terms of why do you think, why is diversity in patient partner perspectives important? So maybe I don't want to pick on someone, but if someone would like to start, and we'll go from there.
I can start. Mm-hmm. Okay, mainly to include the different voices of this research on decision making. We need we have different cultures, different environments. So I think this side of people living with the chronic disease, it's very important, and the language as well, because when you're a researcher, you do so technical things, and I think it's very important to see the other side for many people, as you can hear.
Absolutely, especially on the language and being research just being a lot of jargon. So I really appreciate that, Patricia, your perspective on that.
I can add something, Raissa. So again, I'll repeat what Patricia said, that hearing all the different voices, that's how we're going to identify where the true gaps are. If there are people missing from our research table, that should be a red flag to us about a gap that is existing. A lot of the advocacy that I do is actually ensuring that the voices, I use that word very loosely, of people who communicate differently are also part of the table, whether it's through their caregivers or augmentative communication. It's very important that we ensure that group is also represented and not passed over because it may seem as though it might be difficult.
Yeah, absolutely. I think there's a notion of like you only know what you know, right? And so I think having new folks come in can identify those gaps that really are truly missing. Thanks for that, Stephanie.
Yeah, for me, it's important because patients, that word is generic, so it's disease. People have different diseases, and people are located in different areas. You find patients in the UK, US, Canada, and you find patients in Nigeria, South Africa, Ghana, everywhere with different diseases. For example, in my own health condition is sickle cell disease, but there are different variants. And my own variant is sickle cell anemia. What works in the complications in sickle cell anemia is different from the complications in sickle cell thalassemia or sickle cell beta thalassemia. They all differ. So that is why it's important for you to have different opinion from different patients. And the way I reflect my own complications is different from the way another patient reflects theirs. So that is why it is very important to diversify.
Absolutely. And I know that you've mentioned different subtypes of different diseases. And I think it's important just not only to think about what's the common type out there, but to include other voices who may have rare disease or subset of different diseases that have different lower prevalence or lower rates of it showing up in the population. So I appreciate you all mentioning your perspectives on that. So I'm going to move on to the second question. And I'm also wondering from your end, what is your role as a patient partner in providing others with opportunities? Yes, definitely.
That, Raissa. So I think that that as patient partners or family partners, we do hold a responsibility of ensuring that other people are involved. And it's not, I find with many organizations, they tend to have their sort of go-to because it's easier if they've already got a name, they've got someone who has experience in this. But that limits significantly the information that is going to be shared. So as a family partner, it's if you are approached by an organization that you've done work with, it's perhaps planting that seed and saying, you know, maybe I can help you find someone else who might be a better fit for this or just a different perspective of this. So it's sharing with your communities as well, like as a caregiver, sharing with the caregiver communities the things that are going on and the opportunities that are there. So that includes social media, but also face-to-face contact that you have with people, because we can't just depend on social media. We can't just depend. We need to make sure that we're reaching out to people where they are, finding people where they are.
Absolutely, right. And I think there's also a comfort level too that, right, people would always reach out to the same people. But like how do we break that barrier? And what you've mentioned about having those face-to-face contacts and using maybe social media, but other non-traditional ways to reach people. So that's really important. So thank you for that, Stephanie. Patricia, I think your mic was unmuted for a second.
Yes, I think we must to say the condition do not define us, and we need to spread this. So as an organization, I think we need to embrace these people, to participate more. And the first step, I think, is to let the people know how to deal with the disease, this own condition, how to treat, how to prevent. So I think it's summarizing, it's how to manage all this process, and then to prepare to participate as a meaningful way, saying what is happening with you. I think the storytelling, it's a very good tool to work with the representative in the research to cause empathy. I think it is the most important, the empathy. I think it's what we can do for the patients.
Absolutely, what you've mentioned about empathy, but also having that knowledge sharing and where we disseminate and spreading like removing the stigma that's attached to a certain label. Like I, of course, have chronic migraine, which is a very stigmatizing disease where people are like, oh, it's just a headache, right? So like I love how you mentioned like we can break those stigma attached to our labels. So thank you for that, Patricia.
For me, I think my own personal experience, I think in the issue with being a patient partner, one of the best ways I've been able to include people from my networks is through advocacy. And I think that is one part that can be integrated into being a patient partner. For example, now I've worked with a few pharmaceutical companies and some research organizations who wanted to do research on leg ulcers in sickle cell disease. I don't have leg ulcer complications, but I know a lot of people in my network that had it, and I was able to recommend them. So sometimes, not most of the time, but I think it is important that we could integrate advocacy into being a patient partner, because that gives a very broad opportunity at inviting people, bringing people in. Although apart from that, I've been able to meet other people during research that not just research, maybe while I was communicating openly, because when you have sickle cell, there are times when the signs are visible. So I was able to talk to them and then bring them into being a patient partner. But the main thing for me is, as an advocate, it helps me to bring people into being a patient partner.
Absolutely. I could not agree more with you, Oluwafemi, around the advocacy piece when it comes to being a patient partner. So thank you all for your perspectives. There's been some questions flooding into the Q&A, so I will ask a few of them. So there's a question from the audience. So they mentioned they totally agree it's important to reach people where they are, and that typical research recruitment channels aren't great for this. They are curious if you all have any thoughts specifically for reaching people who are profoundly socially isolated, such as with the decline of X or Twitter. So it can become really challenging. So I'm going to leave it open to the panelists to see if anyone has any thoughts around that.
I think that it's involving people, depending on what your research is around, is contacting the people in that discipline in healthcare. And for me, a big player in this could be social workers. talking to social workers, finding out if they can contact some of their clients that perhaps aren't involved, aren't on social media, maybe aren't coming in regularly for appointments, so that they don't have that face-to-face contact with the people. But social workers are invaluable because they know who's out there. They know what struggles people have, and they might even know how best to support people in being able to come into positions like that to help with research.
Absolutely. I know clinical social workers within hospitals play a large role in patient advocacy, but also connecting people. So they would be a great suggestion. Does anyone else have any other thoughts or would like to contribute to this question?
Maybe
Okay.
I'm sorry, Olaf. No, that please.
Go
Okay,
ahead,
I'm
Oluwafemi.
going
Oh,
to respond to this from this part of the world. Most of those people that are isolated in Africa, let me say sub-Saharan Africa, most people know that our health standards are not as high as those of yours there, but you'd hardly find them. You are hardly able to access them. The best way to do that is to go to the government hospitals, where most of them are admitted or taken care of. And you have to fill a lot of forms, talk to the healthcare providers, and ensure that you are not there to abuse their privacy, because some of them, why they don't want to be how do I put it, restricted publicly, is maybe because of the condition, the specific condition they find themselves. And here the stigma is a lot, and we've not yet been able to manage it properly. So the best thing to do is probably go to the government hospitals, talk to the healthcare professionals before you can now access the patients themselves. That is if they allow it. Other than that, I don't think there's any standard there's no standard process this side.
I think that, I'm sorry.
no, go ahead, Patricia. Go ahead.
Yes. Okay. You need, Brazil is a continental country, so we have many inequalities to reach people with living with some condition. So we need to think about the patients organization. We have a lot of them around the country, and the universities, we do in partnership with universities that can reach us. So we think we have university in all states. I know it's difficult, but the health providers from Brazil, it's a huge endeavor, and so he's doing things that unbelievable, so they can reach those people and to find and bring them to a healthcare professional and participate of any research. It's difficult, it's not easy, but yes, we can do with a lot of work.
Absolutely. Thank you, Patricia and Oluwafemi, for your thoughts. And certainly, right, there's a lot of bureaucratic red tapes when it comes to accessing hospitals and their networks, right? And what you meant, Patricia, as well, with like patient advocacy groups may be also a good step. So it can, it requires a lot of effort, what like you said, Patricia, as well with that. So I'm going to go back to one of my planned questions. So my other question for you guys is that what are you doing to bring other patient partners into your work or into the spaces that you are currently in? And what can others do who are already in the space to bring others to join you into the dark side?
So I think that I'll come back to something we've already discussed. It's noticing who is missing, raising that with the organization you are working with, and figuring out why they are missing. What are the barriers? Is it a financial barrier? Is it a language barrier? Is it, for example, a carer? Is it a time barrier where they're not able to participate because they are providing 24-hour care to someone? And then once you've figured out some of those barriers, what can we do to support those people, to have people feel more comfortable or just be able to actually come forward? And I think with another barrier is that a lot of people might not feel comfortable. They might feel a little intimidated in being in a group of people that they don't know. They're sharing very personal information, but it's also around empowering those people so that they understand that, in fact, regardless of what your background is, regardless of what your education is, you are a professional in your lived experience. And so it's telling people that so that they understand they are an equal person coming to this table. So
Absolutely. Thank you for that, Stephanie. And of course, right, it's that first hurdle of trying to convince someone to be part of that, the part of the advocacy and part of the movement. And I'm going to ask a follow-up question in a bit later, but I am curious to hear from Patricia and Oluwafemi if they have any thoughts.
For me, it's I've done it, but not as eagerly as I should, because there was a time I had an experience which didn't encourage me. I was into a research project, and then I was asked to share a link or bring in somebody that was going through chronic and acute pain with leg ulcers in sickle cell. It was really bad, and I have there's one of my members whose leg ulcer is really, really, really bad, and I've tried everything that I can to see that he gets better treatment, but he is still in the condition. So I introduced him to these people, and the question started back to, when you're doing a research, they check some things to make sure you are eligible. But everything was going fine until I think just one last question. And then he kept calling me, okay, what happened? Have you started the research and all that? He said everything was going on well until the last time. And they were like, okay, sorry, we cannot accommodate you anymore. Why? No responses, nothing. And I'm like, okay, what happened? So I sent them an email. What happened? Why was he disqualified? From what I could gather, I think it's because he was African. And I'm like, but you've known he's African since. Why didn't you tell him he was disqualified from the beginning? I really got offended with that. And since then, I've been a bit hesitant, so I don't raise people's hopes unnecessarily. But over the years, I've tried again to include few people that are convinced that, okay, this is something you can do. It is about speaking for yourself, talking about your lived experience in this in sickle cell and any other thing that you feel is a comorbidity. So that has been my own approach to it.
Absolutely, Oluwafemi. It can be really difficult to establish that line of safety, right? Whenever you're sharing your own story. So I really appreciate the perspective that you just mentioned right there. So Patricia, I know I saw you unmute for a second, so go ahead.
Okay, I'm really sorry for all of this, what you passed. And in Brazil, we have a new regulation from the ethical committees. You must have 2 participants of the research. So two representatives of the societies, and we have difficult to find these people. I'm participate of two, and then many others called me to participate it as well, because it's a law, it's a regulation, it's a regulation, and you have the power of the vote. You can see all the research that you can see many of research, and you are there to give your voice, to tell if this is ethical or not, with your own capacity and culture. So I think it's very important. We are doing this through webinars, so I think it's not for all, unfortunately. And I was invited to participate of the one project on familial hypercholesterolemia, and it's a research, a huge research, double blind, and I'm being part of this. They are hearing me, so it's very different what it's happened with Olaf. So, but it's not enough, because I have the background on research, I start my career on research, then I went to patient advocacy because I have one condition. So it's different. The huge problem is how to bring these people to be a part of I am doing now. I think we need to think more how to do this better.
Absolutely. I agree with you there, Patricia, around, how do we do that, right? How do we bring folks who, in a way that's ethical? And that serves my following question, where Stephanie piqued my interest with the second question, and also Oluwafemi, you kind of mentioned it. We've been talking about bringing new folks into research as a patient partner, and we want to build this diversity. And yet, Oluwafemi, you brought a really interesting point about how do we establish that safety for folks to talk about their lived expertise, right? Because I know, Stephanie, you mentioned that their living experience is just as professional as folks who are wearing the white coats as MDs or as researchers. So from your perspective, how do we build that safety, right? That culture of safety amongst folks who are already established as patient partners?
I think that a big part of that is, I know we're focused in this group, we are patient partners, and the majority as well of our attendees are also patient partners. But there also needs to be education for the researchers on how to work with patient partners, how to speak with patient partners. It's not something that necessarily comes naturally, because for so many years, patient partners were not a part of any part of care. So getting that word out, I am not familiar with programs. There may be some that exist out there for the actual researchers to learn how to work with us, how to respect us.
Absolutely. Education, right? And making sure that researchers would feel equipped whenever they are engaging with patient partners. That's really important. Absolutely. Patricia or Oluwafemi, if you have any thoughts.
I think I agree with what she said. I agree 100%, because sometimes when you come at patients, sometimes some of us are on our guard because we don't know what to expect from you as a researcher, and researchers we could be, you understand what I'm saying? But if, like she said, if they are also trained to learn how to communicate the proper way with us, I think we will do better.
Absolutely, Oluwafemi. Patricia, go ahead.
Yes, just to add, we are not numbers. We are people. Just not numbers.
Absolutely. Very well said.
I
Very
just
well
wanted to add one more thing, Raissa.
Yes.
I noticed Ray put up there, and oh my gosh, you are right. You hit it right on the head, saying that, yes, we offer this training, but the people that sign up are the people that are already doing this. It's how do we reach those people that are not? And to me, it starts with the very top of an organization. The direction needs to come from the top. So I'm talking about the managers, the CEOs. They are the ones that need to set the example and, you know, encouraging or even saying it's necessary. If you are in our organization, you must take this course on working with patient partners or trauma-informed care. So that would be my hope, is that we reach those people at the top so then it works its way. We're working down here, pushing it up, but somebody else is also coming in from the top and pushing it down.
Absolutely. Creating that culture, right, across organizations or even within the system, but the latter is a lot harder, of course. But thank you for that addition, Stephanie. I saw the comment. But yeah, thank you all for those thoughts. We have another question from the audience. So there's a question here, is that in terms of patient voices, I'm considering about representative. My question is that you will bring your own voice into the meeting discussion, or you will bring both your and other people's experiences in the discussion. So what are your thoughts on that?
I think it depends on the context of the research. For me, my own study is focusing on me as a patient and others like me. So it involves my own lived experience and the lived experience of other people. Whereas another particular research, it could be focused on, it could be just phenomenological, focusing on somebody's lived experience. So it depends on the context of the research itself.
Absolutely. Thank you for that, Oluwafemi, right? Because yeah, it really just all depends on the research. It's really difficult to discern, because if you're just sitting in an advisory meeting, it's different than you're advising on research. So yeah, absolutely. Go ahead, Stephanie.
I agree with exactly what you said. You know, when I am advocating for my child, I am speaking only for him. But when I'm sitting at a table, my experiences that I've had with my child are what has brought me to the table. But being aware that there are other people that are having similar issues, or highlighting that, I'm sure, as many of us know, once you start speaking to people who are in similar situations, you see how many of you have the same issues. So it's a combination of using that direct experience with your own illness or your own person you're caring for, but then being so aware that you are being the voice for many others. This is not most of the work that we are all doing, especially in research. We are not likely to personally benefit from it. We are doing this for the other people who are coming down the line.
Absolutely. Thank you for that, Stephanie. Patricia, go ahead. Yep.
I think when you do call to actions, we are talking our voices, it's from the patients. And when I working with some project, I'm talking about familial hypercholesterolemia, and as advocated as a part of an organization who works with patients. But when I work with the ethical committees, I'm brought my experience, and we work at the same level. So yes, it's very different, but it's I remember when I'm in a meeting with the people living with FH, the physician said, "I'm very fearful to talk with you. It's it's easy to talk with another physicians than you, because we go through the right point. For example, are you studying this type of treatment, but I want the cure? We have the protocols that we can find the cure. So please find your cure, and so on. I think our voice, it's very important at all the times, and of course we have many different issues to go to. I don't know. I forgot the word. I have the word
That's
in
all good.
Portuguese, but I forgot. I'm sorry. Sometimes I get stuck on my my
That's
thoughts.
okay.
That
No,
is
no,
it.
I completely understand, right? Like we all come from different experiences, so we all bring that, right? And it's just quite depends on the where you are currently at that situation where you are.
Yes, yes.
And there's a follow-up question to the question I was asking about, like whether you just bring your own perspective with the perspectives of others that you've learned throughout your own patient partner journey. And so the question is that if it is as a representative, what standards of key engagement and transparency are necessary so that you are able to raise everyone's voices? It's a tougher question.
It's a very tough question, $1 million question, but we have to embrace people, teach them to how to deal with the disease, and give her voice with course of leadership, advocacy, campaigns, and raising our awareness. I think we need to reach this person, because as I thought earlier, we are not the condition. We are people living with this condition. So many times in our association, we give the answers, and then the person goes away. The person goes away, and that's okay. I'm dealing very well with this, but you must have the maybe the talent, think of what you I don't know the word, but that's it. I think you need to find something that make that people work for another ones. I think it's
Absolutely, Patricia. Thank you for that.
I think it's just making that acknowledgement, like verbally making that acknowledgement when you are sitting at a table, that you are there because of your experience and you are doing your best to represent everyone, but there are voices that you don't know what their issues are, that you don't. So it's acknowledging that gap, that there are things that are missing. It's impossible for any patient or family partner to be able to speak for everyone.
Yeah, absolutely. And just being mindful of that certainly would be the most important thing. Sure. Okay.
I find that I find that a bit skeptical about that, because I believe that there's always a different complication. So the best I can do, if I'm the one representing my community, I could just give the general complications and then explain in details that, okay, though this is the disease, these are the variants, and for this complication is this and this and this and this, and make them understand that, yes, I'm doing it as I'm representing the community, but there are very unique cases.
Absolutely. Definitely, Oluwafemi. Well, thank you folks for your comments for that question. So there is another question in the audience here is that if a patient partner do not have a research background, what should research team equip or train patient partners with so that they feel themselves as team members?
I mean, going down to the very basic, it's treating them like their team members, calling them team members, involving them in every single step of whatever it is that you are working on. Again, yeah, respecting them as you would any other colleague. That is the biggest piece that you can do. You can find education out there, and there are some phenomenal papers and courses. But again, what it comes down to it is just actually treating those people as team members. Nobody should have to even ask. It's just automatically assumed you are a team member. Treating those people with respect and acknowledging their lived experience. People could not be doing this research without the support of the patient and family patients. Like it's impossible. So it's acknowledging that, which again is something that in the past has never been done. I feel like it's starting, but we still have so far to go.
Absolutely, just the basic human respect. That's the baseline, and you grow from there. So thank you for that, Stephanie, for that answer.
For me, when I say the first time I got involved in a research project, my discipline was different. So I found it it was tough for me to integrate myself into the team because everything was science and medical oriented. But then by the time we got into discussions and all of that, I learned more from each meeting, and I was able to integrate myself into it. So the best thing is, yes, make most patient partners, especially those that are not in the same field, make them comfortable enough to be able to feel not overwhelmed when you're having meetings.
Absolutely with that. I certainly agree with that. Thank you, Oluwafemi, for that.
I think we need to talk empathy. It's all we're talking about, empathy and respect, as Stephanie say. So just to listen, not just hear, hearing. I'm hearing, no, I'm listening you. I want to know more about you. I think it's very thoughtful. Do these things during the meeting.
Absolutely, coming with intention, and just having that empathy as well is really, really important. So thank you for that, Patricia. Okay, so there are two more Q&A questions. So there's another question here from the audience is that are there free research courses for patient advisors? And they're curious as to where/who that they could look to.
I can recommend one that I will put the link in there. I know there are people in this webinar that are very familiar on the program. I am not the right person to speak on it, but I will recommend it and encourage people to go and check it out. It's a family engagement and research course. It's in collaboration with Childkind and McMaster University, I believe, which is a university here in Ontario, Canada. It is free for people with lived experience, parents or caregivers that don't have funding through a research program or organization. I will type it into our chat here. Again, I'm not the right person to speak on this, but I encourage you to check out the website, and there's an address that you can send any questions to.
Absolutely. Thank you for that, Stephanie.
I brought 2 links from this paper about the meaningful engagement of the patient. So I think I don't know if you have with you. I passed to Het, I think, or Dawn, and it's talking about how people needs how to be a patient with a meaningful participation, with right to the vote, and everything else. And I would like to quote something that at the WHO framework from meaningful engagement of people living with non-communicable disease and mental health and neurological conditions. It was launched in 2023, and when Dr. Tedros quotes that people have the right and duty to participate individually and collectively in the planning and implementation of their health and well-being. So I can send the book. Well, you can search for WHO framework 2023, and we have a great research here, great paper to find ways to meaningful engagement.
Perfect. Thank you, Patricia. And Dawn actually has also listed your resources in the chat. So thank you, Dawn, for that. Okay. Well,
Yes.
there is another question from the Q&A from the audience. What types of groups are available for young people with chronic health conditions? And they mentioned fibromyalgia. So I guess this is an open-end question to see if any of you folks are familiar with the types of groups that are available for young people.
I'm not familiar directly with a specific group for that, but looking online through social media is a start, but also checking out different centers in different countries. Again, my experience is all through Canada, but somewhere somewhere that has a chronic pain team, perhaps in their hospital, sometimes they will list different groups. Even somewhere like Holland Bloorview, which is a rehabilitation pediatric hospital here in Ontario as well. They have a lot of resources listed. I'm not sure if they have specific groups, but they do have ways that you can connect potentially and ask questions.
We
Go ahead.
don't have that here in, we are still growing in sub-Saharan Africa, and there are so many things we still don't have access to, and that it's inclusive of what you just asked now.
Well, in Brazil, we have type 1 diabetes group. We have very engaged adolescents and youth working with education, diabetes education. They are very strong on the media. And for familial hypercholesterolemia, we have some groups. And about the research, we have FH Europe is starting the study Perfecto. It's a co-creation to know how to find children and adolescents with familial hypercholesterolemia. And I think maybe it's what I can give you now. But if you type 1 diabetes groups, maybe diabetica, we have a lot of things. You just tag diabetes, then you have a lot of groups in Brazil.
Thank you for that, Patricia. And of course, and to the person who asked that question, I think social media now, just coming from someone who is considered a young person in this age bracket, social media would be your best bet to find like connections for young people within different diseases and just age groups. It is a little bit difficult sometimes for folks who may have more stigmatizing disease versus something that's a little bit more outspoken just within social media. So it is kind of difficult sometimes to find those pockets of network for young people. Okay, I'm going to move to one of the final questions from our planned session. So what types of training or capacity building is out there, and what is happening in different parts of the world? Because I know that Oluwafemi, you're in the sub-Saharan Africa, excuse me, and Patricia, I know you're living in Brazil. So I'm just curious, because we're all just coming from different areas of the world, in terms of what is available and what we could improve on.
For me, there's this global organization I joined as a member organization, and the board and some directors and other healthcare professionals came up with this training toolkit for advocacy and advocacy organizations on how to train them on the best way to go about things. So that is one, and it's the organization is focused on inherited blood disorders, and they are organizing something on training in that area. And there are other organizations as well focusing on sickle cell in Africa, Sickle Cell Coalition as well. They all organize something like this, although it's randomly, it's not continuous, or it's not frequent rather, but it's random. It's not something that we see frequently, but hopefully with time, we in Africa will get there.
Absolutely.
In Brazil, we are doing partnerships with all the sectors. First, the public, the private, and the NGOs. We work a lot with another NGOs and patient representatives. We are co-founders of Brazilian Federation of Rare Disease, the Intersectoral Forum of No Communicable Chronic Conditions in Brazil, and group of advocacy on cardiovascular. We have on WhatsApp group, many WhatsApp groups to bring the voice of our voices. And that's it. We have a lot of courses of leadership advocacy, as I told as well, and campaigns and call to actions. We put all together to have the same level of knowledge. So we are doing a lot, but it's not enough.
For sure, absolutely.
And I'll just again mention the program, the Family Engagement and Research course. That's Ray Martin's course, who is actually on the webinar today. I did put the link in the chat, so I encourage people just to go on and check it out and see if it might be something that could work for you.
That's great to hear. Well, thank you, you three, for mentioning some of the different resources that folks can access here. And I know that we are closing in on time, but I'm just curious for some final words from each of you in terms of what advice or suggestions for the audience to take away from this session, whether that be something from one of the questions, you know, and I'm just curious to see what final wisdom would you share to the audience about this session.
I think something I would say, I'll just repeat something I said earlier, but it's recognizing yourself as a professional, because you are a professional in your condition, in yourself. And it doesn't matter what somebody's background is. Even if people are treating you disrespectfully, you have every right to call them out on that and feel that confidence in yourself, because you know what's best.
Yeah, for me, you are your own voice. Let no one take that from you. Be your voice, and also try by lending your voice, lend it out. You're reaching out to someone else there. So don't feel restricted, maybe based on being ill-treated or whatever. Just lend your voice as much as you can, and don't feel in any way restricted by anybody.
I think you have to write to the right to make your voice be heard, and you are the accelerator of the process of the decision make, and they are doing things for you. It's for you, so they must be hear you, listen you. Just listen with empathy. Don't be afraid. Just do it. Just speak. Just be yourself. It's what it's meant to be.
Absolutely. Those are some beautiful wisdoms that I think folks are going to be taking away and bringing into their in their work. I really appreciate all three of you coming here today, speaking about your experiences and also sharing your thoughts about bringing new voices to research, and just some of the challenges and opportunities that we can build upon as we build patient partner in research. And so I think one of my colleagues is joining now, Rebecca. So I'll pass it back to you, Rebecca, just for final words.
Thank you so much. You guys really had such amazing, engaging content, and the chat was just going crazy. And there's so many good questions and good insights based on everything that you guys have offered. So thank you so much for all of your hard work and insight into this session. So we're going to take a 15-minute break, just 15 minutes before the Ask Me Anything session. This session will not be recorded. It's going to be a chance for everyone to ask any and all questions about patient engagement in research. So we'll see everyone back here in 15 minutes.